Hi, everyone.
Hello,
Um, Welcome to the Elective Egg Freezing webinar hosted by Melbourne IVF. I'm Dr. Violet Kieu, and
I'm Daniel Lantsberg. We're both fertility specialists at Melbourne IVF. It's great to see you join this hopefully interesting talk.
definitely interesting talk. We will, I think, give a few moments to give people time to come in. But just to lay some groundwork, we definitely do have a Q&A in the chat box below. So please, please, please put in your questions and we'll aim to answer them at the end. However, if you truly have a burning question that's relevant at the time, we'll do our best to incorporate it. And at the end, there'll also be a QR code for you to have any more information and have follow-up. So it's not just set and forget this webinar. You have ongoing support in your egg freezing journey. But maybe I'll ask Daniel to introduce himself.
Yeah, so Violet, it's great to be here with you because we know each other for many years and we've been working together. And I think covering the topic of egg freezing is a really important one. A lot of women have a lot of questions about it, a lot of misconception, and a lot of misinformation out there about egg freezing. I think it's a great opportunity to set the record straight. I think the best thing about egg freezing that it's not about choosing a path, it's about creating options for the future. And here we're going to discuss some of those options and discuss what egg freezing is all about.
Yeah, absolutely. So as Daniel's mentioned, we've known each other for many years and worked very closely. And that's one of the beauties of Melbourne IVF. I think as a doctor group, we're very collegial and we talk to each other and we learn from each other. So we are full-time, very busy fertility specialists in Melbourne. But in terms of egg freezing and how that applies to you, take a step back and take a broader look. The things that have changed about egg freezing is the science, society, and the self. So it is in the news a lot. One of the things are that the technology is just so much better than it used to be. We would say before 2014, we used to slow freeze eggs, but now we have what's called snap freeze, instant freeze, vitrification, where we can freeze the eggs so that they retain their fertility potential, not at the woman's age, but at the age of the egg at which it's frozen. So you can be 40, but you've frozen your eggs at 30. They are 30-year-old eggs until we reanimate them. So science has changed. Yeah. What are your thoughts on
Absolutely,
that?
I agree, Violet. Yeah. I think reproductive science has come so far today that freezing eggs is no longer just a medical intervention. It's a proactive step for many taking control of their future life paths, family planning, and their fertility.
Yeah. And I think when we talk about society and self, many of us may think about what we want to do with our professional lives, our jobs. But in terms of our personal lives, there is now more research into what's called like a reproductive life plan. Just having a think, potentially when you turn 30, what your ideal family goals might be. No kids, 1 kid, 2 kids, more, and to really think how you could achieve that with your current life setup or with assisted reproductive technology. And that's really looking at your own goals and what can be used to achieve them.
Absolutely. And I think there was a study that was published a few years ago about misconception about fertility. There was a study that looked at women waiting in a fertility clinic, asking them what the chances of being successful in the IVF treatment. These are women above the age of 43, so women between the age of 43 and 30 and 45. And you know what the average success they predicted for themselves? The average was 50%. So that's whether that's the doctor's fault for not explaining success rates properly, or whether that's a misconception or optimism on the women's behalf. There is a lot of misconception about the ability of IVF to overcome infertility in advanced age. And this is just another example of a study that was published from Australia, taking a similar survey to the study I've just mentioned. And the results were quite similar, even here in Australia. A low a lot of women have misconception about their fertility. And I think if one key message to send out to women watching this webinar is be mindful that the most significant factor impacting fertility by far is age, and more importantly, the woman's age. It's very unfair, but it's the harsh reality that science has come a very long way in terms of fertility treatments, but we have yet found good solutions for the aging egg. And as you mentioned in your starting comments, Violet, when you freeze eggs, you basically maintain, frozen in time, the ability of your younger eggs to create a baby. And that is probably, and we see that a lot. We see the rise in women over 40 coming to fertility clinics and needing to go through repeated IVF cycles and experience repeated failures, miscarriages, which could have potentially have been overcome had they had thought about freezing their eggs at a younger age. That would have made this process seamlessly easier for them. And today we're going to unpack some of that complexity, because egg freezing is obviously not for everyone. Not everybody needs to freeze their eggs. It's a lot to do with life circumstances, stage in life, ovarian reserve. So there are many things to take into consideration. We'll try to unpack that today.
Yeah. And I think I agree with all of that. And what I think is important is that as technology and science has moved to be able to freeze eggs, in our society, whose responsibility is it to provide fertility education? So part of what we're doing today is talking about the issues, in addition, but not to replace, having a one-to-one conversation with a fertility specialist to really talk about age as the number one factor, because there's so many ways to cut the data. You know, there's studies from America saying the best age to freeze eggs might be 32 to 33 years to prevent repeated failed cycles if you were to do IVF instead later on at 40, chasing your tail. We do know that as women, we're born with all our eggs and they're in suspended animation. And it isn't until they are asked to mature that they get reanimated. But once they're reanimated, the cellular machinery might make errors. And that's why the same egg that's collected age 40 might have more errors, leading to infertility, miscarriage, other issues, rather than if it were potentially collected at the age of 30 to 35. But I think we'll unpick quite a lot of those nuances of age.
Yeah, next slide. And yeah, Violet, I completely agree with that. And we have to see this in the larger context, right? Maybe you can comment a few words about how society is changing and why has egg freezing become increasingly popular over the recent years?
Yeah, definitely. So data is collected in many ways, mainly through, say, the federal government. And maybe 10, 20 years ago, the average age of first birth was in the 20s. But today, it's nearly 31 years of age. And there is a lot of sociological questionnaires and trying to unpick why that might be. It's actually multifactorial, and mostly because, for example, a female may not have a male reproductive partner. It isn't actually those myths or other negative misconceptions about wanting to work too much or all these other things, wanting to prioritize travel. One of the things is actually access to a partner, someone that you find that shares your reproductive goals. So, and sometimes you can't control that. Many times you can't control that. So the ability to use technology then potentially to form your own vision of your family in the future is helpful. But it is true, as we do get older, for societal reasons, it may be harder to get pregnant naturally anyway, with the increasing maternal age.
Yeah, and it's true. And I think there's some misconception also that this is only for single women. I see personally a rise in couples coming to seek egg freezing. And this is a result of many circumstances that can vary, whether that's career, life situation, financial situation, whether they just want to travel the world before having kids and they potentially want to have several kids. or they have a partner that's undecisive whether they want to have kids, and they want to leave the time as a primary factor impacting their decision. They want to take it outside the room. So they want to have the option, the freedom to create the family they want to have later on in life. So the many, many reasons for women or couples to come and discuss the option of egg freezing, and we haven't even talked about the medical reasons, which we'll cover today as well.
Absolutely. Yeah. So let's have a look at our next slide.
Yeah. So we know that the thing that impacts fertility most, and I started the conversation is the female age. There are many other factors, important factors impacting fertility, but age is probably by magnitude multiple times the most significant of factors. And we know that it doesn't only impact the chance of falling pregnant, it impacts miscarriages, it impacts abnormalities, genetic abnormalities in the fetus, and abnormalities in the pregnancy that are related to age as a result of the errors that you mentioned. As the age of the egg ages and becomes older, there are more errors in the process of fertilization and early stages of embryo development. And using younger eggs obviously overcomes that. But I think it's also important to know that there's a lot of misconception about how well eggs can be frozen as well. And you mentioned that we are currently using a new technology that's been around for over a decade now called vitrification. Because in the past, when we started egg freezing 40 years ago, and I'm happy to say that Melbourne IVF was one of the pioneers in Australia, creating the first egg bank for medical egg freezing for cancer patients. Back in the first days of egg freezing, eggs barely survive the freezing process through slow freezing. We're talking about 2% survival. So the technology wasn't there, but over time, that technology has evolved significantly. Today, we're talking about 92% of eggs surviving. Most eggs will survive the freezing and thawing process. And that's a really important myth too, because we still have patients Googling, should I freeze eggs or embryos as an example? Because I remember 15 years ago, we would have women looking to create embryos because egg freezing technology wasn't there. But and there's still some websites quoting that freezing embryos is a better alternative than freezing eggs, which is not really the case. I think it's important to unpack these myths so women and couples can have a more sense of security about this advancements in that technology, as more and more evidence is coming out in terms of success rates, long-term impacts of egg freezing. And we're still at the, in an emerging field of science, but it's definitely evolving and it's showing very, very good promise.
Yeah. In fact,
yeah.
I was just going to say, freezing your eggs is like being an egg donor for your future self. So it's creating a unique resource that really can't be replicated through any other process. There's nothing like it. It's your unique genetic material. And that we went through one of the slides that actually we do not recommend and actually stop collecting a person's own eggs after the 46th birthday. And I, see several 46-year-olds and they're healthy, otherwise they're fit, but actually their reproductive health, the chances of them having a live birth from eggs at that age are less than 1% and closer to 0. So the years do matter because human fertility is quite ineffective and not every egg becomes a pregnancy. So sometimes it's balancing the number and quality of eggs that one might have at a younger age rather than the lower number and the lower quality at an older age.
Yeah, I completely agree. Next slide, please. I think we're talking about increasing age, and is that a unique thing that we see here in Australia, that we're having our firstborns at a later age? Actually, this phenomena is worldwide, and women are having their firstborn at a much older age than before. And if we talk even, a decade ago, the firstborn would have been around the age of 20. So society is going through a change, and we can't ignore that change. And science has come up with certain solutions. They're not optimal, they're invasive, they require planning. I think at the end of the day, it's a deeply personal decision. There's no one size fits all when it comes to egg freezing. And the most important thing is that women feel informed and empowered to make that decision. And part of that is having such an education session like today to give the information to women to make the best decision for themselves.
Yeah, I really like that. I think it's really important to look at it in the global context, because we're in a time of great paradox where there are the most number of human beings in the world, but the actual reproductive rate, or the number of children per woman, is at its lowest. And so there's multi factors, and how do we address that and care for our aging population, but also support women, not just say egg freezing and access to assisted reproductive treatment, but also broadly childcare and all those other things that can feed into having a life that balances personal and professional responsibilities.
Absolutely. And let's dive a little bit into the science of it. Next slide. So we mentioned before that women are born with certain amounts of eggs, and we wanted to show you what an ovary looks like at birth around the age of 25 and around the age of 50. And you see these round, bright shapes. Those are called primordial follicles. These are the follicles that are where the eggs lie at a dormant state. And women are born with all the eggs they're going to have. Actually, the most amount of eggs that you will have is actually when you are yourself a fetus at 20 weeks, where you would have about 6-7 million eggs. And by the time a woman is born, that number would have already dropped significantly to about 1 million, sometimes even less than that. And throughout lifespan, women will lose their eggs, not just by ovulation, because we tend to think, oh, women ovulate about 300-400 times in their lifetime. They will lose 300 or 400 eggs, and that's it. But that's actually not the reality. Each month, there is a cohort, a group of follicles that leave their mature state, the immature state, the dormant state, and they start developing. One of them will make it to ovulation. The rest will just undergo cell death, will die. So most of the eggs lost in this process actually do not even ovulate or use, they just undergo cell death. And we actually take advantage of that fact in the process of egg freezing. And we have the skill and ability with medications to rescue those follicles and help them grow. And what this slide shows is how those number of primordial follicles decline. And we can't create new ones. And there have been all sorts of ways of trying to maximize and recruit more follicles that are dormant, but we don't have a good method to recruit follicles that are not there. It's as simple as that. And there have been all sorts of treatments that have been offered, and some of them you'll hear in the news or on social media. But bottom line is that nothing is really very effective in overcoming the depletion of eggs and the declining egg quality. So next slide, please.
This is a big question. So you'll hear both of our thoughts on this. But AMH stands for anti-Mullerian hormone, also sometimes referred to in social media as the egg timer test. So the way I explain it or think of it is you've got your 2 ovaries, and as a genetic woman, you're born with all the eggs you'll ever have. Each of these primordial follicles, or teeny tiny eggs, they're really jealous of each other. They want to keep everyone small, so they release this protein, the AMH, so they're all small, so they're all tucked in when you're a little girl. And it's only when you hit puberty, your brain matures to release follicle stimulating hormone, and in a perfect cycle, matures 1 egg per month until 50 or so. But, so the AMH actually is a protein that has a function. It keeps all the eggs small. But it's also cleverly enough, if we measure it, we can say if that number of AMH is a normal range for your age group, or a lower number or a higher number. So I would tell people, please don't fixate on the exact number, but interpret it. And interpretation is key in the context of your age and the range. Is it normal or unexpectedly low or unexpectedly high? And then we can unpick it. And actually, even with a low AMH, a lower egg reserve, if you generally have a regular monthly period, and if you ovulate one mature egg per month, you are not infertile by the definition of how likely you are to fall pregnant per month spontaneously through unprotected intercourse with a male. If you have that mature egg per month, you are as fertile as another person, even if you're low AMH. But where the AMH is helpful is it can guide us into thinking, is this a medical or elective issue? And also how we might dose medication to try and do our very best, as Daniel says, to save or rescue the other follicles that are available that month. What's your take?
I think I get a lot of referrals, patients coming to me worried that they have a low AMH, thinking that they're infertile. And I think it's a very important point that you're making, Violet. AMH does not describe or depict in any way your fertility. What it does, though, it gives us an estimation that we can use to try to estimate how many eggs you've got left. And AMH value doesn't mean the number of eggs, it's a relative number. And it's also very, very key in the process of any fertility intervention, because it helps us predict the outcome. It helps us adjust the protocol and the medication used to get the best result. And I think an AMH test is a very important test to undertake for anyone who's not ready to have a family, to have an understanding of where things stand. And unfortunately, a small fraction of women doing that test will uncover that they have very low ovarian reserve. But I am more concerned of women at the age of 35 thinking that they have a high ovarian reserve, that they've got plenty of time. It's true that they will ovulate for much, probably longer than a woman who has low ovarian reserve, but AMH does not in any way describe the quality of her eggs. And as a woman ages, the quality of her eggs will decline, which is a lot more worrisome compared to an egg number. And I don't know if you would agree with me, Violet, but in my practice, younger women with low AMH have much better results than older women with high AMH.
Yeah, I think anecdotally, I would say, yep, I'd pay that. And I think one of the other things, we can talk about AMH like seriously for an hour and a half on itself, but when and I guess maybe when you go to see GPs as well, general practitioners, some of them do ask, should they be doing the AMH blood test? And I say to anyone, a patient seeing a GP, if a GP is comfortable in their wheelhouse of ordering it, interpreting it, or even have a plan if it's abnormal, or to have a referral pathway to a fertility specialist like us who can, or who has the time to unpick it more in the unique context for that individual. I think that's I think AMH testing can be done, and can be done at the GP level safely if there is a follow-up plan.
I absolutely agree. And I think also having an AMH result before your consultation with the fertility specialist will make that encounter a lot more productive in terms of taking the time to interpret that result and tailoring a specific plan for that specific person or a couple's reproductive goals. So I think having an AMH test done is very useful, but it has to be interpreted, not just based on a Google search. It has to be given a very precise and educated discussion. So generally speaking, AMH doesn't need to be done by everyone, but if you're looking to have a fertility discussion, family planning, see where you are in your reproductive span, I think it's a very important test to undertake, and it will be taken if you haven't done it before seeing a fertility specialist. That's one of the first tests the fertility specialist will request for you to do.
Yeah.
Next slide.
You know what? We've got a question in the question box. I think we should answer it.
Right. How
Yes.
exciting.
Can you test eggs for quality?
Oh, that's such a good one. All right. Do you want to take it or me, Violet?
Go for it, and I'll
all right.
have some
So currently we use age as the most reliable predictor of egg quality, but and we base our estimations on success rates based on age and averages for that particular age. Now, there have been many attempts to try to grade eggs in high definition microscopes, and all those attempts so far have yet to yield a good prediction model based on all the parameters that we've checked, to estimate what the true likelihood of any particular egg to create a pregnancy. Having said that, there are very exciting things in the pipeline, current studies that are being conducted, and I'm happy to say that Melbourne IVF is also involved in that, in looking into AI models. Violet herself, and maybe you can elaborate a little bit on that, but we're using advanced technology and AI to try to look closer at those eggs and have a better prediction on what the outcome of each egg will be. It is, to my understanding, Violet, we're hopefully getting close, but it's not yet a viable technology to be used in a clinical setting. But we are hopeful that in the future, with the advances that we're making and the huge technological advances that are happening in recent years with AI, that this will come into the clinical world, and we'll have better models to estimate success rates from frozen eggs. Violet, maybe share a few words about what you're doing in that space.
Oh, no, I was actually yaying Melbourne IVF, not anything too involved in there. But it's really good learning from each other, because you've talked about AI, but I would talk about other things as well. So this is great, actually. So when I talk about quality, or when I think about percentage per egg to become a baby. Yep. And then we do have mathematical graphs that we look at, and actually the percentage of a frozen egg, it's under the age of 35 can be around 5% or so, and then it does decrease over, as you age, to under 1%, in that mid-40s. So it's modest to start with. And I guess one of the things I want to tell people is there's that reanimation of that egg that's been there your whole life, and then it does its final mature division into a mature egg, that we can't, well, you could do a genetic test on that egg, but because it is one single cell, you wouldn't have anything left after you've tested it. So you can't test that egg. Whereas sometimes in the future, or, in older women, we test embryos, which are hundreds of cells, and taking about 5 cells or so, we can have a look at the genes to make sure that it's a normal genetic embryo. And then that gives us some understanding about the quality of the embryo. So exactly, we don't have any really good tests in clinical use for quality, and thus the major default is the woman's age.
Yeah, and I think it's a very important question to ask, because we do know, we encounter that some women, and also the data suggests some women with 20 eggs we say 90%, close to 90% of them will have one child, but about 30 or 40% may have 2 children from those 20 to 30 eggs. Yes. But we still have that 10 to 20% who will have no children from those eggs. Yeah. And being able to predict who those will be is extremely difficult, because it relies on the quality of the egg. It relies also on the quality of the sperm. It relies a lot, and a lot has to be said about the quality of the lab in which those eggs were frozen. To freeze eggs, in a way, I can say easy, because you're not really put to the test. The real test is when you thaw those eggs, and success rates in different clinics vary quite widely. And they vary quite widely depending on the location where the eggs were frozen. Of course, thawing eggs is important, and that skill is also very, very important to have. But actually, the way in which those eggs were frozen is probably more important. And that's where science comes into play and experience. Every lab can theoretically freeze eggs, but very, very few labs have proven success rates from those frozen eggs. And this is where experience comes into great play, and is a huge factor.
Yeah.
Next slide. So we've said so much about this throughout our conversation so far. Age, and I wouldn't agree to the statement that it's best to start a family before the age of 35. It's best to start a family when you're ready to start a family. But when you are, the readiness, I think, needs to take a lot of different factors into consideration. There's so many different factors. Evidently, we're seeing the rise in age for firstborn because society is changing, personal circumstances and personal journeys in modern life is changing. And we have to take that into consideration when thinking about having a family or the desire to have the option to have a family. And that is probably the most important factor, that if you were to take one message from here, is not to be afraid or to be scared of your fertility declining, but rather address this question early on, as early as possible. I don't think we would necessarily recommend freezing eggs for somebody who's very young, who's 25. Do I have a 25-year-old patient freezing eggs? Absolutely, I do. And because I currently have a patient who took a random AMH test and uncovered she is very, very close to hitting menopause, very unexpectedly, for no known reason and no family history. And these things can happen. And it's always important to have this discussion at a younger age. I'm not suggesting that 25-year-old women should freeze their eggs in general. And as you mentioned, studies probably show that the best time to consider this is around the age of 32, 33. But if I had a patient at the age of 32, 33 coming to me and say, I want to have one child, and I'm thinking just starting next year, I don't think she would be a good candidate to freeze her eggs. Circumstances vary from one person to another, and these need to be addressed and discussed under those particular circumstances.
Absolutely. And one of the other things about egg freeze that you mentioned as well is it's not just the freeze, it's the return to use, the thaw, and the outcome. So just putting that in a story, I had a lovely school teacher. She froze her eggs in early 30s. Now, a number of years have passed. She's come back and we warmed them, fertilized them, put back in an embryo, and she's pregnant. And she looked at me at the scan, of the pregnant scan, such big eyes. I didn't think this would work. And I was like, oh, wow, because you separated the time of eggs to the time of conception. And we don't know, of course, until we actively come back to attempt a pregnancy. And it can work. Of course, we cannot guarantee any biological outcomes, but we have standardized stats and emerging proof that we are getting pregnancies and live births from frozen eggs.
Absolutely. And I think I always try to think, are we really biased, you and I, Violet? Because we feel the frustration of failures of women with advanced age, and we see the successes of pregnancies of women who had frozen their eggs. And I think our worldview can be sometimes distorted because this is what we're dealing with. These are the challenges. And when we see women in their 40s really struggling, we just hope that we would have been able to offer them a better option. And but as you mentioned, not all women will come back to use their eggs, if they freeze their eggs. Sometimes they won't want to have kids. Sometimes they manage to fall pregnant naturally without our help, not needing to use those eggs. And as you said, there are many, many reasons to freeze their eggs. Maybe it's good to see the next slide, because women come to freeze their eggs for many different reasons, don't they, Violet?
Yeah. Happy to talk about this. You already mentioned so what we're talking about prevention against age-related decline is collectively referred to as elective. Um, you will age, time just marches on. And so making an intervention now to freeze eggs, that's a choice that you're making. And elective, I think, is a better word when it used to be called social. That sort of maybe made it more flippant. So this is an elective choice. In a way, even proactive health, like sometimes people, for different reasons, may have screening to do colonoscopies or screening. So in a way, this is a sort of proactive health measure. So we call it elective. But then sometimes people have, also as Daniel's mentioned, his 25-year-old with a surprising low AMH, a medical reason. They may have that premature ovarian insufficiency, that premature menopause earlier than the average at 51. And so if we identify it, that is something that we can do urgently to help freeze eggs, knowing that there may be a other medical condition that's acting to hamper or decrease those egg numbers and quality in the future. Did you want to maybe talk about some of these medical conditions as they pop up on the screen?
Yeah, and we'll also address the question in the Q&A. I think it's a very important one. We'll talk about that in a minute. But when we talk about medical conditions that may warrant a discussion about medical egg freezing. So blocked or damaged fallopian tubes is an example of somebody who would need IVF anyway to start a family. And if they are reaching to an age where they are wanting to plan ahead for their family goals and wanting to have better success rates at a younger age, they would need IVF anyway. So fertility preservation is definitely something that they should be discussing, whether that's in the form of egg freezing or embryo freezing, depends on their circumstances. On-court fertility is probably the biggest indication in the context of medical egg freezing. These are women who are about to undergo intervention to treat the cancer, whether that's chemotherapy, radiotherapy, or surgery that may potentially damage their eggs and ovarian reserve. And this is true not just for oncological reasons, where usually time is more pressing for the intervention of medical egg freezing. Also other conditions like endometriosis, which we know is strongly associated with infertility and decline in ovarian reserve and egg quality. Fibroids, I would say they would not be a good indication for egg freezing unless there are very, very specific circumstances where conception has to be delayed significantly due to fibroid surgery. But even in those cases, the delay usually is quite minimal. It's usually around 3 to 6 months, depending on the surgery type. So fertility preservation should be discussed in those circumstances, but egg freezing per se, not necessarily. Premature menopause, that's probably, women who are identified with extremely low ovarian reserve who are about to lose their fertility. And in those circumstances, they would likely to require multiple cycles to bank eggs to give themselves a chance for having a future child. And that would also be a medical indication. Now, a question we got in the Q&A, and I think it's a very important one. Somebody asked do they need to go off their contraception to have an AMH test and have an egg collection with Mirena, and how long should they be off contraception before it? So I think there is a misconception that they need to be off contraception before it. So let's maybe unpack some of the impacts of OCP or oral contraceptive pill on AMH levels and also Mirena. Violet, do you want to answer? Your take on that?
So yes, I do have an opinion. So the oral contraceptive pill is usually combined estrogen and progesterone in a low, stable dose that you take every day, usually 3 weeks out of 4 weeks, and that 4th week you might bleed if you're on a sugar pill. But really what it does is by having that constant estrogen progesterone, it sort of blocks your brain, like your brain doesn't have to signal the follicle stimulating hormone to recruit and grow an egg in your ovary. So your ovaries are in a way dormant, all the little eggs are little. And that's how it's a contraceptive. You don't have a big mature egg that you could fall pregnant with. We do know that the OCP can, so the oral contraceptive pill can suppress that AMH release because the ovaries have been quiet. So I do recommend, because here's the difficulty. If you're on the your oral contraceptive pill and you do an AMH and it's low, it could be a false low, a suppressed low. So then you probably would want to be off it for a month or two of washout and then test it again to see if there's a bit of an increase to get a true reading. So sometimes, to avoid people double handling 2 AMH blood tests, might recommend they come off for a month or two. You know, if they haven't done the AMH and I was going to see them in a month anyway, you come off the pill, do the pill closer to when I'll see you again next, the AMH, and then we'll have a potentially more accurate result. So definitely the OCP can suppress the ovaries. What do you think?
Sorry, I love that. I love that approach. And a lot of times I have this discussion with patients. I say, you can have an AMH. The downside of having an AMH test done while taking a contraceptive pill is the $90 they spend on that test. And sometimes taking a contraceptive pill is quite important to that person for many different reasons, whether that's pain or symptoms associated with their period, whether that's actual need for contraception. And I say, if we do a test and the levels are normal, then we don't have to repeat it. You don't have to be off it. But if we do the test and the results are abnormally low, then the option would be offered to be off those contraceptive pills and a month later retest. We have to remember that there are also other modalities of assessing ovarian reserve. So we can look at other things apart from AMH to see, to have some kind of reflection of ovarian reserve. Most importantly is through an ultrasound test, measuring what we call antral follicle count. So these are tiny follicles in the ovaries that can be assessed even while you're taking a contraceptive pill or have a Mirena in place. By the way, Mirena can also reduce artificially the AMH results, making the AMH not as accurate as it would be without a contraceptive pill. Do I think, sorry, do I think women should take the Mirena out to have an AMH test done? Absolutely not. I think it's not a pleasant procedure to have a Mirena taken out, or even more so inserted. And we can try to interpret the results based on antral follicle count in combination with the AMH test results. And especially we can do egg freezing and the stimulation of egg freezing with a Mirena in place. Actually, a lot of women use egg freezing as an opportunity to replace their Mirena while they're under for the egg collection. So to avoid that discomfort of placing in the IUD. So I think that's another take on this. What do you think about that, Violet?
Yeah, exactly. I think it's the multiverse. You just cut the information a different way. So either you come off the pill and you do one test, or you do it the other way. You do it when you're on the pill and it's normal. You don't have to do a second test. So it's just a different way of cutting the data or looking at things. I agree. The Mirena itself, because it's low dose progesterone, that is like a matchstick inside the uterus, it thins the lining. So it doesn't always impact ovulation, actually. So yes, I do very often stimulate with a Mirena inside or in situ, because our follicle stimulating hormones are strong. We would expect to recruit eggs. But I've also, from time to time, if people have lower egg numbers than expected, I may suggest we take up the Mirena for a next time. And certainly if someone have a medical egg freeze, that's something I think of as well, if we're already looking at lower egg numbers. So again, no hard and fast rules, but real consideration. I think that's what this shows, that we consider things. And it's not a tick box exercise. Yeah.
Absolutely.
Yeah.
There's another question asking about AMH in the 25th to 50th percentile. For her age at 35 will be considered medical reason for egg freezing under Medicare provisions. So the short answer is no. Medicare provisions for egg freezing require us to assess for a condition that may cause infertility or may cause imminent infertility or soon after. And also a condition where a significant damage to the ovaries has already been done by an intervention, whether that's surgery, chemotherapy, or any other intervention that could have damaged ovarian reserve, or such an intervention is about to be applied. It doesn't have to be cancer. So to have low ovarian reserve or just under the average ovarian reserve, in no way that doesn't meet any criteria for medical egg freezing, unfortunately. All right.
Let's see what's next. Yeah.
How many eggs do you need to freeze? The holy grail. The short answer is as many as possible, right? But of course, everybody has a finite number that they ideally would like to freeze, and I think it's really important to understand the notion that the more eggs you've got, the better the odds of you achieving a live birth from those frozen eggs, and the older you are, the more eggs you will need. Nicola, are you taking this up? Yeah, thank you. The more eggs you will need to achieve a live birth. So for women under 35, we say ideally between 20 and 30 eggs is probably the perfect number to have a very good chance, would say about 90% chance of having one child. Some women may say that I'm about to get her ovaries removed and they want to have 3 kids, then those numbers would change accordingly. And some women may come at a later age. They would need more eggs to achieve the same likelihood for success. So egg numbers should be adjusted to a woman's age. And these are numbers that we quote in our consultation. So any woman coming to me, based on her age, I'll be able to tell her how many eggs roughly she would need to aim for to achieve a good chance for one live birth. And at the same time, based on an AMH, an antral follicle count, I'll be able to have an estimation of how many eggs we can achieve in one cycle. And it's important to say that more often than not, women may need more than one cycle to achieve their goals. Sometimes it's achievable in one cycle, but sometimes you would need more than one cycle to achieve those numbers.
Yeah, I agree.
Yeah.
So in a rule of thumb, again, depending on age and egg reserve, there are different ways of thinking about it, but one may largely say an average number of eggs is sort of a median or an average of 10 with a range of 5 to 15, and under 5, so that's 4 or less, is a low responding person, and more than 15 is great, but also runs risks of lots of eggs, lots of hormones, of ovarian hyperstimulation syndrome. So we call them a high responder. So even just taking that number of 10, modest, times 2 cycles, 20 times 3 cycles, 30 in very, very broad terms. But another way I tell people as well is, let's say that 10 is, let's say it's 12. 12 mature eggs frozen is like compressing a year's worth of eggs that a normal woman would be ovulating each month for a whole year. So one intervention, if you get 12 mature eggs, is literally saving the equivalent of 1 year's worth of fertility chances for the future. Again, it's about chances and not any guarantees. But that is a way of thinking about it. Another way of thinking about it, again, relating to age, over the age of 40, 80 to 90% of those eggs might be genetically abnormal or so. So we need to really increase the number of eggs we're collecting if we are over the age of 40 to have a chance.
Absolutely. Absolutely. Next slide, please. So let's talk about the stages. What does egg freezing look like in practical terms? So, Violet, somebody comes
looks like
to you,
this.
wants to freeze their eggs. What happens?
You talk to one of us. That's what it looks like. You think about your reproductive life goals, what you might want to do with your fertility. You see a GP, get a referral, and speak to Daniel or myself. And then we spend, up to an hour just going through everything, the medications you've been on, any other medical issues, all the things that we've discussed before, any risk factors for the endometriosis, the pain, heavy periods, etc., irregular periods, all that we do. But it's not just a one doctor workshop. It really is a team. And Daniel's alluded to the fantastic lab that we have at Melbourne IVF. But I'd love to introduce you to also our really dedicated nurses, counselors, and support staff. So I'll talk about it from my perspective because you might run it slightly differently, but you'd come and see me, hopefully with the AMH, so we can go through a plan. And then I'll give you some time to think about, what we've said. I wouldn't see you once. I would send you away and have a think, and then see you again. So you've had time to read the consents, understand the pros, cons, risks, alternatives to egg freezing. And some of those alternatives are not to do egg freezing, to have had a good conversation about fertility and do nothing. Great. You've had a conversation. You might choose to egg freeze. You might even choose to say, actually, I'm ready for a child now. And that's either with my partner or with donor sperm or such. So it really helps clarify what you want to do now. But if you choose donor eggs, then we would have a discussion, and I would do a referral to the nursing team to go through what the medications look like, safe handling of drugs in the fridge, the yellow bin to dispose of sharps, what phone numbers to call for help, where the pharmacy is, etc. And also the counselling, information counselling about how eggs in the state of Victoria can be legally frozen for up to 10 years. And then after that, we just have to tell the state government if our intention is to continue storing for another 5 years or so. Also, we talk about, and I'm going to say what might happen in the circumstance if a person passes, and what their instructions might be for eggs that are frozen. So we very clearly have plans for what respect actually for the frozen eggs. But then let's say you've had your doctor talk, your nursing talk, your counselling talk, and you're ready to freeze your eggs. What does that actually look like?
Yeah, absolutely. And also during that encounter, we send them to do some investigation. So a lot of them will not have an AMH test, a pelvic ultrasound. It's also a good opportunity to have an overlook of their gynecological situation, whether they've had, pap smear recently, to see if we can predict any possibility of any future difficulties in falling pregnant. And sometimes during these encounters, we encounter medical conditions that need to be managed, need to be controlled. And sometimes somebody coming for elective egg freezing may become a medical egg freezing. So let's talk a little, we lost the slides, Nicola, if you can bring them back. So basically the process of egg freezing, what that involves is about 9-10 days of injections. Those sometimes can be even reduced in terms of number of needles. There are ways of doing that in particular circumstances, that those need to be discussed for women who are more needle phobic. Classically, we used to talk about starting these stimulations around day 3 of a woman's cycle, and that's the traditional IVF cycle. But nowadays, we actually have also an option to start this at any point in their cycle. It doesn't have to be limited to only when you get your period, but there are certain nuances that need to be addressed, and those are things that you will discuss with your fertility specialist. So during those 9-10 days, you'll undergo usually a couple of scans just to assess the development, and we monitor the number and the size of follicles that grow in your ovaries. And the point mostly is to adjust any dosing regimen and to time the best time to collect your eggs. The egg collection itself is a procedure done under sedation. That means you'll be asleep. Now, in different states, different places, different units, that is done on women while they're awake with local anesthetic. At Melbourne IVF, we believe that the women have the option of doing that, but we do not offer that by default because we believe that this should be pain-free. And the process is not painful at all. The egg collection, you'll be asleep, you won't feel anything. And through the vagina, we extract the follicles from the ovaries. Now, complications from that procedure are extremely rare. It's a very common procedure. Violet and myself do this every day. We rarely see complications arising from this procedure. And luckily, this is a result of many years of gaining experience and technology that has evolved to having really excellent needles and excellent ultrasound machines that show us very precisely what we're looking at and avoiding any potential harm to be done to any pelvic organs around the ovaries. So after the egg collection, you will go into recovery. You will wake up very slowly, have a drink, then have a sandwich and a snack. And about an hour after the procedure, you will go home. Now, when we take those eggs, the lab is literally in the theater. We will know straight away how many eggs are being collected by the scientist who collects those eggs from the fluid that we aspirate from the ovaries. And they will tell us how many eggs we've got. Now, that number is not a finite number because it's not a final number because those eggs need to be assessed for their maturity. And that is a process that will take a tiny bit longer. So these eggs are dissected in the lab, not the eggs themselves, but rather the cells that surround the eggs prior to the process of freezing. So we need to actually check if those eggs are mature before they're frozen. So most eggs will be mature, but not necessarily all of them. Some eggs may potentially be immature, and those eggs are normally not frozen. So we only freeze mature eggs because only those eggs have the true potential of creating a future baby. And then we freeze those eggs. And following that cycle, you'll have a discussion with your specialist about the outcome of the cycle, what that entails in terms of your future probability. And have a discussion, is this fulfilling your goals, or would you potentially want to have another cycle? Now, we'll also discuss the expectations versus the outcome. Have we exceeded our expectations? Have we matched them? Have we underperformed? And if we have underperformed, can we look at the reasons why that happened and maybe adjust to different medication, different protocol in subsequent cycle? All these things will be discussed with your specialist. We've got some questions, Violet. Yeah. So
yeah,
do you want to take some questions?
Yeah.
All right.
So I think leading on to that would be, is it painful to have an egg collection, post egg collection, i.e. meds, injections and recovery? So I look at this way. Day 1, you report your period. Day 3, start injections. Around day 14, egg collection. That day 14, it's a day case. And so you go home day 14, and I mostly recommend people take day 15, the day off after as well, and then resume normal activity. Though I did have a patient on day 15, the day after, telling me she was doing cartwheels, but she was a great person in general. But yes, that's not my expectation, but if you can do it, you can do it. But in general, I say it's a needle in the ovary. And you can have a bruisey pain. So have a heat pack, take Panadol if you need, and also have a pad or panty liner because there might be some spotting overnight. What's really good, Daniel's talked about the lab, they will likely print out on discharge the number of eggs collected, with a caveat, it's not exactly the number that may be frozen, and you'll either get an email that night or contact the next day with lab with the frozen number, but also the next day you get contact from the nurses to see how you're doing. And that's really to make sure that your pain is managed, that you aren't soaking, a pad an hour like a heavy period, because that's not our expectation. And thus then we can help monitor you, bring you in, or take other further measures to take care of you in person. So in general, only requires regular oral analgesia or pain relief tablets after egg collection.
Yeah, I agree. Most women continue about the daily routine pretty quickly after. During stimulation, they may report some discomfort in the pelvis, and this relates also to the next question: is does hormone therapy have any major side effects such as mood? So during the stimulation, you may experience some mild side effects. As I said, the majority of women continue about their daily routine. The most common side effects I hear, and I don't know if that's the case with you, Violet, as well, is fatigue.
Yes, extreme tiredness. That is the one. So I tell my tax accountants not to do it during tax time. Do it. Yeah.
So, but other side effects that you can potentially encounter is some breast tenderness, it does sometimes create a bit of mood swings and mood changes. Pelvic discomfort is probably another very common one. But I think the take-home message in general from the side effects is that most of them are quite mild and tolerable, and most women continue about their daily routine during the stimulation. But yes, they do need to take a day off, definitely on the day of egg collection, and I recommend at least one more day. And the more eggs you would get at the egg collection, the more discomfort you may feel after, and the recovery may take more time. So sometimes, and that's a discussion I also have with my patients, do you prefer that short-term pain and long-term gain attitude and stimulate a bit harder to get more eggs at the expense of having more discomfort after the egg collection and a slightly longer recovery? And that's case-by-case decision that we make. Because in certain instances, we have the option to control the level of stimulation, the number of eggs that we can retrieve. In cases where the ovarian reserve is low, then the maximum number we would get would never be high, even if we were to strongly stimulate the ovary. So it's a case-by-case discussion. There's another question here in the Q&A. This is Kirsty, asking, if my 36-year-old partner froze her eggs and I carried in my early 30s, would there be more chance of success rate? Compared to what? I don't know what, Kirsty, you're referring to, compared to what, but obviously younger eggs is better always, but is there a huge difference between 36 and 30? Violet?
So a couple of things. I was just going to say, with the other question about the mood swings, we are thorough. And if a person has a history of any mood disorders, a regular counsellor, GP, mental health plan, psychiatrist, we would definitely be wanting to involve them, letting them know that we are doing an IVF stimulation so that everyone is across multidisciplinary at the time when we're doing medications. So yes. Now, I interpret this question, I guess, if it's a same-sex female couple and the person asking the questions in their early 30s, but then they use their partner's 36-year-old eggs in their early 30s, would there be more of a chance of success? And I would say with Daniel that let's say your early 30 means 30, that's 6 years max of different age group. Early 30s could be 33, it could be even 3 years, but let's say it's even up. There's two ways of thinking about this. One is not really, because the lining of the uterus is regenerative. It has a basal layer. So, of course, it sheds its decidual, like, the trees that shed their autumnal leaves. And that's why we can actually put an embryo into a woman up to the age of 51, the natural age of menopause. So in terms of success rates in implantation, barring anyone having any fibroids, polyps, endometriosis, chronic endometritis, absolutely. Then no, not really. I guess the only other thought is there is that thought over the age of 35, it's an advanced maternal age pregnancy where there are actually potential other risks to the pregnancy in the woman. The 36 is very mildly over 35, but this could include things such as diabetes, blood pressure, etc. So again, these are sort of things that one will discuss on an individual basis.
I completely agree, and that's the bottom line. You need to personalize your advice based on this particular circumstances. Age itself is not the only factor to take into play in these situations of what we call reciprocal IVF. Yeah. Another question before we move on in the sake of time: can I move my eggs once they're frozen? The short answer is absolutely yes. Definitely when it's within Victoria and interstate here in Australia. When we're talking overseas, it's a bit more regulation around that. But the short answer, yes, you can move your eggs. Most important is to consider where you freeze your eggs. And the second most important factor is where you thaw them. If you haven't done the first thing right, at least you do the second thing right.
Wowzers.
All right. So how long can you freeze your eggs for? So in Victoria, as Violet, you already mentioned this, we're talking about 10 years limit, but obviously this can be extended with some paperwork, and time does not impact the eggs. So it doesn't matter how long they've been frozen for. What matters is how old you are when you froze your eggs and how old you are when you use those eggs in the context of pregnancy-associated complications and during pregnancy and delivery. And Violet mentioned some of those before. Next slide.
Just with the egg freezing, a factoid is that we snap freeze the eggs to around minus 196 degrees Celsius, and that's when biological activity just pauses. So that's why we can freeze indefinitely. So when people say, oh, do I have to use them within a few years? Is it better than using them in 10 years? No, the short answer is no.
Yeah, so a common myth that I hear sometimes people say, oh, I've got 6 eggs, so I don't need more than 6 children. So that should be enough for me. Obviously, that is not true because we know there's an attrition rate from the eggs that you have preserved to the final results of a pregnancy. So we say the survival rate of egg thaw to nowadays at Melbourne IVF is 92%. It's not true for all centers. The average around the world is sitting around 85%. And from those eggs who survive the thaw, we need to fertilize them. And we know that not all eggs will fertilize. Fertilization rate will depend on sperm quality, age of the egg when it was frozen, but we say an average of about 40, sometimes higher % of fertilization. And from fertilization, we want to grow these fertilized eggs into day 5 embryos, what we call blastocysts. And general rule, sorry, I mentioned fertilization 40%, I was mistaken. We're talking about 60, 70% fertilization. The 40% was related to the blastulation, which is the rate of which fertilized eggs will develop into blastocysts. And that, again, varies from one person to another. So, and some women from 10 eggs may have 1 embryo, some may achieve 3, and I've seen women achieve also more than 3 embryos from 10 thawed eggs. But we also seen some tragic cases where 10 eggs resulted in no embryos to transfer. So these numbers that you see here are averages, but they may vary from one person to another depending on a lot of different circumstances. Next slide.
And some of the circumstances can be lifestyle. Yep, we're all different.
Absolutely.
Yeah. So there's lots of lifestyle factors and lifestyle information. We as fertility specialists, one of the big bodies is the Fertility Society of Australia and New Zealand, and they actually do have patient information sheets on many different lifestyle things. So that's a resource that you can have a look at as well. But generally, I'll list them first, but coffee, alcohol, healthy diet, exercise, healthy BMI, smoking. So these are all things really everybody knows, but doing the basics right can be hard, right? Just applying that. So if you think about an egg is a single cell, and you just want to get the cell, as healthy as possible for its ability to mix with sperm and become an embryo and become a baby. Now, some of the ways that I talk about it is extrapolated from pregnancy data. For example, there are studies showing more than 6 cups of coffee, that's a lot, per day is associated with miscarriage. So then there are different ways of saying some studies up to 2 coffees a day is fine. So 2 is some way away from 6, but it is sort of dose dependent. The more is more. In terms of things such as alcohol, again, in pregnancy, there's no lower limit. You know, they do talk about effects on baby brain, facial development. So no alcohol is the safest, and then any other alcohol is a risk. But so in general, I tell my patients, you know, eggs from their teeny tiny to the most mature takes a number of months. So the best time to take care of yourself is in the month or 2 leading up to your egg collection. So if you try to abstain from alcohol, that's a good time to try doing it. But also don't set yourself a really difficult task like during a social period that might be Christmas for you or whatever it is. So try and really do what can be integrated in your own life. And if you have 1 glass of alcohol, don't punish yourself. It's just 1 out of 2 months, really. Other things
Yeah,
such as smoking, for many reasons, don't smoke. And sometimes actually thinking about fertility can help a woman or a person or a couple think about their health in general. And again, GPs, other resources, quick resources, even, you know, we have access to obstetric physicians if people are trying to get pregnant, other ways just to optimize health. And
absolutely. And my,
yeah,
my comment to
your
this would
thoughts?
be also regarding to the question that we're getting, which is how long prior to egg freezing should someone consider adjusting their lifestyle in preparation for an egg freezing cycle? My first answer would be adjust your lifestyle as early as possible for your own sake, not just for your eggs. If you have bad habits like smoking or heavy alcohol drinking or unhealthy diet, excess of caffeine, this is making those lifestyle will benefit you. But if we're looking into a more narrow point of view in terms of your egg freezing process, eggs to mature from the dormant primordial follicle to a mature egg that will ovulate, is a process that on average takes about 200 days. Sorry, maximum of 200 days, but most of the time will take around 3 months. So we recommend making those adjustments ideally 3 months prior, but there is some benefit to even up to 6 months. Not that I would suggest delaying this by 6 months, but the benefit will probably sustain over that whole period of time. But generally, as a rule of thumb, most eggs that will mature are within they have matured, the process of maturation, meaning the exposure to all these lifestyle factors will be over the course of mostly the 3 months leading up to the egg collection. So if you've got time, start today. That's the best time. But if you want to time your egg collection and you're limited, 3 months is probably ideal. What's your take, Violet?
That's great. That's great. In terms of other things there, just very, very briefly, things such as exercise. Well, there are guidelines saying, we haven't addressed this, but other health metabolic conditions such as polycystic ovarian syndrome, the very base level of discussion is at least 3 times a day, 30 to 45 minutes of moderate activity. So these again are just very general guidelines that we can recommend. There was a slide there that mentioned body mass index, and we do know that is a crude measurement of health, but it is something that we can calculate. And looking at it as well, even from a purely medical point of view, by having anesthesia to do the egg collection, we do look at the body mass index to make sure that if it's higher, fine, but we're just in the most highly accredited hospitals to manage your procedure most safely. So again, these are things that we in a non-judgmental way do look at, yeah, for safety.
For the sake of time, I think we're going a bit longer than expected. So we're going to move on to the slide of complementary therapies. A general rule of thumb is, and this is by very personal choice, Violet, you can say what you think about this. I have no objection to complementary therapy. I was myself once a patient as well of complementary therapy. I think it has to be done by a trusted practitioner who knows what they're doing, who are not supplementing interventions that could interfere with the process. We know that some supplements may contain hormone-like acting substances, so they need to be experienced and trustworthy providers. But we know that complementary medicine has a very good impact on a person's well-being while going through these treatments. And if you have strong belief or you've been a previous patient of complementary therapy, I would definitely recommend continuing pursuing that. What's your take, Violet?
Yeah, definitely. Even from a medical point of view, in Victoria, they did a study on people who did acupuncture during their IVF. And whilst there wasn't a significant difference in the number of eggs, etc., there was a huge difference in people's well-being, their experience of the journey, their ability to reflect, and I guess cope with setbacks or reflect happily if things were good. So definitely, we're doing an egg is a part of a person, part of a system. So yes, we work with you.
Completely agree with that. Next slide. So
Yep.
I think first point is important here. No number of eggs is 100% guarantee for future live birth. But we can get close to that, close in terms of percentages, but there's never a guarantee. There could be unexpected things that happen in the future when you come to use those eggs in terms of sperm quality, embryonic development, and embryos that don't implant. These are all scenarios that can happen. In terms of long-term data, one of the limitations of this technology that's become widely used, mostly in the past just over a decade, is that we don't have very long conducted studies. Women freezing their eggs in the early 30s may resort to using those eggs only 10 years later. Sometimes they want to have their first child at 38, and they want to have more than one child. As a specialist, I would recommend save your eggs for your second child. So it requires long-term follow-up on these eggs to really give precise numbers. And we used to quote most studies that had 5-year follow-up quoted around the 10% return rate. But we know that in the last year, there's been a large study that took a much longer follow-up of more than 10 years. And we saw the return rate was over 30%. So although that was not conducted in Australia, but still it does showcase some of the varying numbers that we see in studies. What is important that is all across the board in these studies is that more than half of women freezing their eggs will not be using them. And I think that to be actually a good thing, because it means that they've succeeded in their family goals, and they had the family that they want to have without need to use the insurance they've created for themselves by using those eggs. And you should know that there is a likelihood percentage of women that would freeze their eggs and not need to use them, in which case they would have the option of doing many things with those eggs. They can choose to keep them frozen, discard them. They can donate them to somebody they know. They can donate them to somebody they don't know. They can donate them to research. They're your eggs, the woman's eggs, and every woman can decide for herself what she would like to do with her unused eggs in a case where she decides that she no longer needs them.
So I would add to that as well. Another way of looking at it is the biopsychosocial research, when there are questionnaires about people's experiences of freezing eggs. And there are surveys in Europe, USA, Australia, that the overwhelming 90% plus people do not regret freezing their eggs, regardless of any of these different endpoints that Daniel has mentioned. But there's a small subsection of people who actually write down that they regret not freezing earlier. So it is a decision, not at just one point, the point of freezing, but also the point of return to use. And I think as an established unit with physicians or fertility specialists who deal with this every day, we can help guide you through these nuances so that you're not alone in decision making.
We have a question about costs, which brings us to the next slide. Violet and myself as doctors are not involved in the payment aspect of the treatment. Luckily, we can focus only on the medical aspect of your treatment. We do have a dedicated team at Melbourne IVF who will discuss the cost with you and payment options. And all the numbers that you see right in front of you on the slide are readily available on our website, melbourneivf.com.au. You can go into the cost section and all these numbers are outlaid there. So you have a clear path of understanding what egg freezing involves. It should be clear that medical egg freezing obviously is quite different to elective egg freezing because there is a significant rebate for that, and also possibly use of some of different insurance policies for some of the costs involved in the medical egg freezing. But these can be discussed on every very personal level in particular circumstances with our finance team. So let's summarize this last slide, Violet.
Yeah. So look, I think we care not just about the cycle, but care about the person. And in the laboratory, we care about the science. So I think we are unparalleled in Victoria. There's many of us who've had extra qualifications, experience in overseas units, experienced in male fertility, in surgical procedures for high risk endometriosis. We are a team that has expertise in this area. And if myself or Daniel are stumped, not often, but if we are, we all talk to each other or even talk to our other colleagues, getting advice from the laboratory unit. For example, as Daniel's really clearly outlined, there are times we exceed expectation, meet expectation, and if it's not what we expected, we'll go into the lab and even talk to the lab managers what they think may be things that we can change for next time. So it's our experience and expertise, I think. What do you think?
I think the key thing, and as much as I have huge appreciation for our group of doctors, and especially you, Violet, whom I know for many years, and see you as the rest of the Melbourne IVF team as great specialists in caring for our patients. I think the primary thing that I'm mostly proud of is our lab. I think people underestimate the importance of the lab and how much is being put into a good lab to have the success rates that we have. And there is a reason why we're leading in terms of success rates. The reason is we invest into people, we invest into equipment, we invest into experienced scientists who are very skilled. And this is where we put our money. And that's why we have such great results. And for me as a clinician, it makes it much easier to advocate the use of Melbourne IVF for egg freezing or IVF, because our results are widely published and anyone can access them and they can see our results. And that makes my job a lot easier. So have great faith in our lab. And I think that's a key thing that people don't realize how important it is.
Oh yeah, here. I have one more quick thing to add, though big. We have the largest and most established donor team. So just going to say, it's exactly Daniel's point, where you freeze and where you thaw. I do have patients who come and bring their eggs to us because where they've frozen don't have access to donor sperm, etc. So having our excellent lab and our access to a complete fertility treatment. Yeah.
Absolutely. All right, let's see if we've got any last questions before we conclude. All right. For how long? Okay, we answered that question.
Yeah.
Well, the cost, we answered that question. Great. So, yeah. All right. Would like to thank you all for tuning in and listening to this conversation about egg freezing. I had a great time. And if you have any questions, you can always reach out to us either through the Melbourne IVF website. There's a phone number there to call us, and you can contact each of us, Violet and myself. We have a phone number for our private rooms where you can have a consultation with us as well.
Yeah, absolutely. Not only that, I think Daniel's quite humble, but he's part of this Big Miracles TV series. So you may see him on your media as well. But I truly hope to let you know we're just down to earth people who see this in and out and can help offer some real information that may make a difference in your life in the future. So yeah, thank you for your attention.
Thank you, everyone.
Yeah.